members who've joined today for this talk. I'd just like to say a big thank you to the Migraine Trust for inviting me. I know this is the first, I hope, of more meetings involving people with learning disability and autistic people, because it's something that I've discovered that is not much information out there. So I've prepared a presentation, and if you just bear with me, I'm just going to share my screen, and I'll give you a little bit more information about the talk. Okay, I'm just going to check, Debbie, is that clear? Is that showing okay?
Yeah, that's perfect. Yeah.
So this gives my name. My title is Specialist Doctor in Learning Disability, and I work with the Humber Teaching NHS Foundation Trust. I'm talking to you from my home in Bishop Burton near Hull. And I thought I'd just start off with a little outline of what the talk's going to be about, and then explain a bit more about why I'm doing this talk. So my background is that I'm a specialist doctor in learning disability, and you might say, well, what's that? And it's a good question, because until recently in the UK, there wasn't such a thing. And it turns out, I think, that I'm about the first person with this particular title, because in the past, doctors that had an interest in learning disability tended to be psychiatrists, and they were the people who looked after people when they had learning disabilities. And it's only recently that my position has been created. So I'm going to just explain a little bit about how that came about. And then I'm going to explore about why I thought it might be good to explore this issue, and why the Migraine Trust invited me to come along and give this talk today. And then at the end, we're going to have time for some questions and a discussion. So I hope that all makes sense. But if you'll forgive me, I am going to just go back a little bit in time and think about, how I've got here to this position and starting this talk. So my role is, as I said, as a specialist learning disability doctor. Another name for it is an intellectual disability physician. And nobody's quite decided what to call us as yet. And this role came about after, if we go back, I think we can trace its origins back to in 2001. So talking about 21 years, 22 years ago, there was a government white paper, and it was entitled Valuing People. And what this was looking at was recognizing that going back for many, many years, there'd been poorly coordinated services for families with disabled children. And this was particularly for those with the more severely disabled children. And they recognized there'd been poor planning for disabled people when they transitioned into adulthood, and that carers of people with children with learning disability and adults of learning disability felt that their needs weren't being catered for. And it was the Prime Minister at the time was Tony Blair, and I think he had a personal interest because within his family, one of his relatives had a learning disability. I think it was his son. So he had an interest in this going forward. And this paper promoted the idea of bringing together health and social care organizations together with parents and carers into groups, which they called a partnership board. And on this partnership board, a local mum called Jean Carlin, who had a daughter called Erica, who had very profound and multiple learning disabilities. And she joined this board and helped to set it up and worked with them. But she realized early on that the board was very big. It included, so many different people, and she didn't feel that Erica's needs were being met. So she suggested to have a specialist subgroup of the board for the PMLD patients. These are ones with profound and multiple learning disabilities. And that got set up, and Jean was instrumental going forward subsequently to my position being created. So I'll tell you a little bit about Erica. Erica was very unwell around this time, and she was suffering from constipation. Now you'd be thinking to me, well, why is Patrick talking about somebody with constipation? He's meant to be talking about migraines. And you're right, Erica doesn't have migraines, but it just helps if you understand how I came to be involved, and then you'll understand why we're talking about migraines. So Erica was so poorly that the nurses and the doctors told her mum that she needed palliative care. There's nothing more that they could do for her. She's at high risk of a bowel perforating, which means a little hole being created because of the pressure of the poo inside. And when that happens, it's a bit like a burst appendix, but you couldn't operate because there'd be nothing you could do. So Erica was very unwell, and the nurses referred her to the palliative care doctor. And the palliative care doctor was called Dr. Leah van der Plaat. And she worked with the family in a holistic way. And she supported Erica and her mum and Jean, and the family. And she liaised with the different specialists that were involved. There was a neurology doctor involved who treated Erica's epilepsy. There was a gastroenterologist doctor who was treating her bowels. There was her GP. There was the learning disability nurses, and there was a whole host of other people involved, including the feeding team, because she had a PEG. And eventually, Dr. Leah van der Plaat, working with the different doctors in a holistic way, she managed to get Erica better, even though at the time it was thought she was terminal. And her mum was so astounded by basically what appeared to be almost a miracle for Erica. And this is a picture of her, and how she looks now, actually very happy. Yes, she's got a profound multiple learning disability, but her quality of life is excellent. And she's very happy. And Jean Carlin wrote this paper with other people on the partnership board to get a doctor involved. And that's how my role was created, because she persuaded the CCG at the time to put some money together to fund this role for 2 years, for people with learning profound and multiple learning disabilities living in Hull. And that's basically what I've been doing now for the past 2 years, working with people with these disabilities at home, with their carers at home, in day services in schools. And I'm part of a much bigger team. So I see people with all different levels of learning disability, because we discuss them in meetings, and sometimes I get asked for advice. And in January this year, I went along to the Migraine Trust. No, sorry, it wasn't the Migraine. It's the British Association for the Study of Headache. And the Migraine Trust were represented there, and they had a stall. And I met Rob and I met Debbie at this meeting. And it struck me, because I've been listening to all these talks about migraine and the new advances in treatment, and how important it was to recognize and treat migraine. And I thought, well, I hadn't come across anybody with a learning disability that was on any treatment for migraine. And so I asked Rob and Debbie about this, just, what do you think? Are we missing them? And Rob and Debbie were kind enough to, to explain that they too hadn't really come across this as a particular issue. So I thought it'd be worth exploring it. And that conversation, a few weeks later, when we discussed it and met again, led up to the idea of me looking into this situation and coming back to them about it and doing a talk. So thank you, Rob and Debbie, and subsequently I met Steph as well, who invited me, and we've been working to do this presentation, but it's all my responsibility, not theirs. So anything that I say that isn't quite correct, they're going to pull me up on, I'm sure, because obviously my background isn't with migraine, and I hope that you'll understand that I'm not talking as a specialist in migraine. I'm talking very much as a generalist. My background is as a GP. So when I was appointed, I didn't know a great deal about learning disability, and I've had to learn it very quickly and become a more of a specialist. But I found that my background in general practice has been really helpful. So I'll just recount, for those of you who've joined who haven't got much understanding of migraine, I'll just, if you don't mind, just go briefly over what migraines are, because I know many of you will perhaps have very good experience and will know a great deal about migraines, but some of you may not, and we're not sure exactly who would come along today. So it's a recurrent headache. It usually lasts between 4 and 72 hours. And particular features are that people become noise sensitive and light sensitive, or feel sick or actually vomiting. And as well as these features, two of the following features are unilateral pain, which means on one side of the head, pulsating pain like throbbing, moderate to severe intensity. These are quite unpleasant headaches and made worse by physical activity. So if you've ever suffered with a migraine, I hope that fits in, because that's the classic description. I have sometimes get migraines myself, so I do recognize it. I'm very lucky because I don't get them very often, but when they are there, they do interfere with my work, and some people's lives are made a complete misery by them. And it can be very, very difficult to live with. So it's quite a serious problem. Other things that some people get are auras. These are like flashing lights and zigzag lines in your vision, and sometimes even transient loss of speech. And it's thought that what's happening here is that at the beginning of the migraine, there's some constriction of the blood vessels in the head, and that causes an impaired blood supply to parts of the brain. And this makes your brain malfunction, basically, and particularly in your vision. So seeing flashing lights, zigzag, black and white lights, and sometimes it can be just loss of one side of the visual field. So it's quite frightening. And sometimes people think they've had a stroke if they've not had this before, and they turn up in the casualty department with these symptoms. So that's kind of a brief description. Another thing that's classic with migraines that people may recognize is triggers. And I just wonder, is it okay, Debbie, if I just ask the audience if anybody has got migraine themselves, or is looking after somebody with migraine, if perhaps they could shout out or type in the box about what triggers affects them. I can tell you my triggers, and sadly chocolate is one of them. So I have to be careful with chocolate. I still eat chocolate, but I know that sometimes I will get a migraine headache. So it is, but they're not so bad that I stop eating chocolate. So I have to confess. And also, if I get tired, that I are under a lot of stress, they're my triggers. But I just thought, is anybody would like to share what triggers their migraine or their person they care for's migraine? I can't see, so Debbie, you'll have to tell me if
I
anybody
can tell you.
says
So
anything.
there's a few in the chat. So being too warm,
Yeah.
hunger,
Yeah.
stressed or poor health, like when you've got a cold and that sort of thing. And another one for stress and tiredness, and thunderstorms as well. So there's a
Oh
few
yeah.
variables there.
Yeah, environmental changes, that's a big one. It's really odd, isn't it? There's so many different ones. So I've kind of summarized them down here of hormonal, dietary, emotional. Sorry, I jumped back there. Emotional, physical, the environment, the thunderstorms, and also medication. As a GP, it was something when I started somebody on the pill, I always tried to remember to say, look, just be careful, because sometimes the pill can trigger a migraine. And if somebody had a history of migraines with auras, we used to be very careful not to start the oral contraceptive, because in those people it can make them a lot worse. And I just so migraine features often, now tension headaches, which is a different type, can also be caused by tiredness and stress. So it's not just migraines that are caused by this. So you may get tension headaches with similar sorts of things, but some of the migraine triggers are particularly close. And in foods, I think people talk about tyramine, which is in certain cheeses and smoked meats and things like that. And one of the things that people with migraines tend to do, if they're having problems with them, or the doctors will ask them, or the nurses, or the people from the Migraine Trust will mention it, is keeping a diary, a symptom diary and a food and drink diary, to try and pick up what the problem is. And I just mentioned these images that I'm using have been kindly given permission by Jessica Hernandez and the graphic medicine website, because I find graphic medicine pictures sometimes really helpful. And Jessica had migraines and she's drawing her story here. And this is her curled up in her bed, kept feeling sick, the pain, the nausea, the sensitivity to light and sound all kept coming back for days at a time, just being able to endure it. So that even making a noise is too much. And I just thought it was such a good description of a migraine. I thought I'd use her pictures. So, and the Migraine Trust, as they do have a very good link to a diary for this type of thing. So I mentioned before tension headaches. There's also migraines, obviously, and then there's cluster headaches. These are kind of the primary headaches. And then the secondary headaches, which are kind of due to other reasons. And one of them, a common one, is medication overuse headache. And this makes lives for people with migraines very, very difficult because they're using tablets and medicines like paracetamol, ibuprofen, and things like that. But if they keep using them more than perhaps 10, 15 days a month, they can get a medication overuse headache, which means they just get more and more headaches, and they end up in a circle of misery, really. And it makes treating migraines sometimes very difficult because you have to start using different drugs and avoid using drugs, and you often need some help and support. And again, that's why somewhere like the Migraine Trust is really useful to be aware of. Because if you're suffering with migraines, trying to navigate these problems, it's very difficult on your own. They're the three types of headaches which I've mentioned, and obviously today I'm concentrating on migraine, but part of the role of the doctor is to help you figure out which type of headache it is. And sometimes you can have a mixed picture of tension and migraines. And sometimes there's something called a cluster headache, which is very different, but it comes on in a very severe way and causes changes in your eyes and makes your eyes water. And it's very incapacitating. And you can get 6 or 7 in a day, and it lasts for a period of a cluster and then goes away again. But I just mention it just for sake of explaining the different types of headache. So briefly, again, I know that many of you will already know far more than me about migraines, but just for the sake of people who are joining with more of an interest in the learning disability side, prevention is better than cure, and absolutely true when it comes to migraine, both with acute migraine symptoms and if people have chronic migraine. Avoiding the triggers, good sleep, regular meals, hydration, exercise. I'm sure these are all things that you have come across before if you've got migraine, but if you haven't, these are the kind of things that can really help to avoid you needing to have medication. I've mentioned some of the common tablets that we use. There's also anti-sickness medication that's used for sickness, but also just on its own can help treat migraines as well. So they're commonly added in. And then there's drugs called triptans, which are really, really good for some people for acute migraines, but they don't suit everybody because they cause the blood vessels to constrict again. Do you remember I said that the migraine, first of all, the blood vessel constricts and then it dilates, it widens out, and that's when the pain starts. Well, the triptans reduce them down, but the side effect can be that you get a tight chest, you can have some restrictions, and if people have had a history of heart disease, then that's not a really good treatment to use, so they have to be avoided. So there is a bit of a problem with finding the right treatment. Preventative migraine treatment is very similar. Prevention is better than cure. And each person has to be looked at individually to try and work out which is the best kind of prevention for them. Sometimes it's simple tablets like beta blockers, sometimes antidepressants work, and sometimes anti-epilepsy medications can help to prevent. And each person has to be looked at carefully to try and choose with them what's going to work best for them. for example, somebody who's also got blood pressure, taking a beta blocker, which is a blood pressure treatment, might be ideal for them. But for somebody who's got low blood pressure and tends to faint, the last thing you'd be wanting is to give them a beta blocker, because it would make them faint more. And of course, some people can't take tricyclic antidepressants. They could be on some other medication that could interfere with it. They're an old-fashioned type of antidepressant, but they can work really well to prevent migraine. There's some newer drugs as well, and I'm not going to go into real detail about these. I'm sure the Migraine Trust will have a lot more information on their website, and I did look at that, and they've got some really good information about these newer migraine treatments, and they starting to work at the heart of what's going on. We're still not certain, because they don't work for everybody, so it's not like a cure. There isn't a cure for migraine, sadly, but they do work really well for some people. And we know that this calcitonin gene-related peptide is part of the migraine story, but it's not the whole story. And this will need specialist referral to get this treatment, and it's given by injection, sometimes every month, sometimes every 3 months. And it's a really good treatment. So if it sometimes is a lifesaver for people, but you need to have, as I say, a specialist referral. I don't think GPs are giving it out at the moment. So how does this all fit in with learning disabilities, and what can we make of this? Because the situation is there's all these different medications, there's all this different type of preventative work for migraines, and I think there's some real good progress lately in the last few years with discovering some really effective treatments. But as I said at the beginning, people with learning disability don't seem, on my radar anyway, to be presenting with migraines. And this is what made me ask the question back in January, is to, are we missing such people? What's going on? Carers, sorry, just to explain a bit more. One of the issues that there is with people with learning disability is often they can't give a really good verbal description of their story. With a learning disability, they have an intellectual impairment, and sometimes they can't verbally explain what's been going on, and they rely on carers to help them to explain, to understand. They might have an understanding but not be able to put it into words, or they may literally just not be able to understand the words for that particular problem, but carers can get to know them and understand what they're saying. So I've spoken with carers about these types of problems, and what they've said when I've spoken to them about people with learning disability when they're unwell and they're having pain or they're distressed, is that health professionals don't value the knowledge and skills that the carers possess in their role and disregard their contributions. And I found this quite surprising, because with being a GP in my background, not knowing that much about learning disability, I found the carers were really helpful. And part of my work has been to work very much alongside carers and listen to their specialist expertise about their patients. And whenever I go to see a patient, I kind of say, well, what's this person normally like? What's their usual behavior, and how they communicate? How can I understand their needs best? And it's the carer that tells me. So if you don't listen to what the carer knows about the person, then there are clinical complications. Things go wrong. They end up being admitted to hospital when they don't need to be. Carers, on the other hand, say they don't have the necessary technical language for communicating with healthcare professionals. So there's quite a big barrier to carers really being able to explain what symptoms people with learning disabilities have. And as I mentioned, sometimes people with learning disabilities will appear to understand something, but the carer will identify this might be a stock response. And some will say yes when they mean no, and no when they mean yes, and they get things back to front. And sometimes, as I said, they can't say words that mean anything, but sometimes meaningless words actually do mean that they understand and fully. So it's quite a trap, and it takes a bit of time to get to know somebody. So what I'd like to suggest to people who are working with people with learning disability, to try and understand what the symptoms may be and if they might be suffering from a headache, is these questions: what do I need to know, and what is this person usually like? And we need to also put in more training for people to understand soft signs of illness, because sometimes people with learning disabilities, and particularly the elderly as well, with dementia, for example, they don't always show a clear sign that they're unwell until they're very poorly. Instead, they might have just a little subtle change in behavior. You know, somebody might stop doing something that they normally do. We call these soft signs of deterioration. And there are training programs now being put out around these things, and I would recommend them. And in the slides that I think we'll be sharing, Debbie, is that right? I've put down in the notes about the various training programs that are available, for example, for spotting soft signs. And there's also the Oliver McGowan training that's coming through, which is for all healthcare providers to undertake. And I've undertaken that training, which was put on by Oliver McGowan's mother, explaining why it's important to understand. Oliver sadly died in medical in a supported living environment because his family, the carers, had not realised what his needs were. It's also important, again, to be registered with your GP if you've got a learning disability, to have an annual health check, and also for reasonable adjustments to be made. And another thing that can be helpful for people with learning disabilities is for them to have a hospital passport, which lists all the different reasonable adjustments that somebody with a learning disability may need in order to get the right care, for example, if they're admitted to hospital. There's also some tools to help identify pain. They have people with learning disabilities might have a different way of showing pain, and I went through different evidence-based toolkits to try and find out what would work best. So one of them is My Pain Profile, which helps supporters to think about the signs that somebody's in pain. Another type of approach is a pain-centered pain picture. There's the disability assessment tool, the DISDAT, which identifies each person's own vocabulary of distress signs. And there's an 18-item checklist as well. And again, all of these are in the notes to the talk, which will be shared. I say My Pain Profile could be useful for somebody who's experiencing what appears to be pain. A person-centered pain profile, for example, involving the person's family and carers to try and identify when they're in pain. And this would be similar to using the diary that we mentioned before that the Migraine Trust has had, but using a more individualized approach, because obviously people with learning disability, they may not, well, they probably won't be able to fill in the diary. They'll need someone to help them. And using some of these tools could be really helpful. And I've got links to all of these in the notes from the presentation. And they've got a diary in the DISDAT tool as well. So overall, I after doing all of this kind of looking into to migraines in people with learning disability, I've come to the conclusion that in learning disability, we're not identifying people with migraines because of the difficulty identifying it if they're non-verbal. But there are tools that can be used to identify pain, and then migraine can become one of the differential diagnoses. There are system things as well, which the Right Care Toolkit, if you've probably come across that in the Migraine Trust, I'm sure. I don't know whether you suggest it as a toolkit that's helpful, which looks at the correct identification and diagnosis of headache disorders. That's part of the thing that for me as a learning disability doctor, I've got to do some work on, and I must admit I'm still not there. I've yet to diagnose migraine in somebody with a learning disability, and this has made it quite difficult for me to prepare this talk, because I'm asking myself why. And the person that I'm thinking about, who I think we may have missed, and there are similar cases across the patch of people I'm working with, are people who have menstrual related migraines. Now, migraines affect women in particular, and people when they have periods sometimes get migraines actually triggered by the period, and there's ways to identify that from the diary. But what we've been doing as learning disability specialists is we've been identifying that it's just the period is causing behavioral changes, and we've taken treatments and done treatments to help stop the periods. But I think what we've probably missed is part of the reason the behavioral changes are happening could be because of migraines. And the treatments that we've used have actually worked because they've stopped the period, but we haven't maybe explored whether perhaps a migraine treatment, either an acute treatment or preventer, could have worked, because the patient hasn't described it as a migraine. They've instead behaved in an uncharacteristic way. We've seen that they're in distress and made an assumption that the distress is caused by painful periods. It's possible. I have got no evidence to prove that, but I now will be looking much more carefully. For example, would it be associated with somebody being sick as well? That might be a clue that it could be a migraine. So that's one of the things I'm thinking to take forward. And then there's also supporting patients to manage their condition after diagnosis, making referrals to appropriate referrals to secondary care, and looking to long-term management. So these are systemic things that people can do to try and improve migraine management in the community. And with reference to learning disability as well, I think that needs to come into the equation, and I'll be looking forward to finding out what you think, and if there's anybody got any ideas or suggestions, because it's clear that this is an area that we still haven't really got to grips with. And I think across the board, we may be missing signs that somebody with a learning disability is suffering from a migraine. And I'd be grateful for any ideas and suggestions of how we can look to investigate that. I've done a list of some of the references that I've used, and I'm happy now to take any questions and to have a discussion, because I feel that, as I said, I've only really just made a very early start on this whole story. So thank you very much for giving me the time to have a chat with you. I look forward to discussing anything that comes up.
Thank you, Patrick. That was really informative. Really appreciate it. If anybody's got any questions or suggestions for Patrick, pop them in the chat, raise your hand, just shout them out. That's fine. But yeah, we've got Patrick for another 25 minutes, so lots of time for any questions that anyone might have.
Thank you, Debbie. Yeah, I really tried hard to find evidence looking in the clinical papers, and there are some papers that talk about learning disability and migraine, but they all tend to be in children, and they're really quite complicated. They're not talking about specifically migraines in people with learning disability. They talk about pain and recognizing pain, but not about migraine. And I'm surprised, because the statistics show that maybe 1 in 5 women have migraines? Would that be about right? 1 in 5 or 6?
1 in 7 across the board, yeah.
1 in 7, yeah. And is it 1 in 15 for men?
Yeah, around that, yeah.
Right. So if we're looking after hundreds of people with learning disability, and we discuss them regularly, and I've not come across anybody on regular migraine prevention. So that I don't understand, because I'm sure we're missing something, but I don't know how to address it. And I don't know whether there's anybody here that's somebody's put a question. How would you suggest we effectively communicate that the issue our resident experiences migraine appears to run in his family when they repeatedly record in their notes and comments support as a headache and only offer? That's a really good question, Jessica. Yeah. How would you communicate this? I think is it possible for you to come on to the call, Jessica, and just let's have a chat with you? Because I think I'd be.
Yeah, that's fine.
Hello. Hi, Jessica. Welcome. Yeah, lovely to meet you. And thank you for listening. You've got a resident with what appears to be a migraine from the sound
Yeah,
of
so
it.
he came to us over a year and a half ago. I've only been in the home for the last year.
Yeah.
And he came with kind of spotty medical history. He was an emergency placement.
Yeah.
So his transfer of documents from his previous get across. His dad has migraines, his sister has migraines. They're all treated for it.
And that's really important point, Jessica, because family history is a big factor in migraine. So that's a big clue, to ask. So you've spotted that. So there is
we've only
he's
recently
got a
started
risk.
noticing the symptoms. So he's
Yeah.
started. We've noticed that he's blinking a lot. He's completely non-verbal, and he does
Yeah.
have quite high communication needs. But he started blinking a lot,
Yeah.
and that's something that we think is kind of the precursor, the warning signs. But so
Right.
far, when
Yeah.
we say migraine, she repeats back to us headache. And,
Headache.
no, we're not.
Yeah.
We're not headache.
I mean, this is like, I know it's not good for your patient in one way, but it's music to my ears because you're describing exactly the issue, that this is
Yeah.
somebody who could well have migraine, but because of his or her learning disability, he's not being listened to really,
Yeah,
that
and I mean,
you're, as his
this lad
carers,
will
aware there's a
basically
problem.
smash his head into concrete walls. He will bash his head
Yes.
into walls. He will
Yeah.
grab at his own head. He will punch holes in walls and is scratching at his face. And then to get the
Very,
kind of
very
response back
distressed.
from the GP saying it's a headache, give him paracetamol. We're really struggling how to kind of get it
Yeah.
across.
And has he had paracetamol when he's had these headaches? Can I just check
He's had
that?
paracetamol. We're now gearing more to trying to, like you said, with preventative. The second that we see the blinking, we're trying to use it then, because we know that that's effective with his dad, because we've spoken to his dad about it.
Yeah.
And then we also have cocodamol, which is one that seems to take the edge off when he gets into like a proper migraine. But the cocodamol, like, it wears off quick. It really wears off quick.
And there is a danger with these types of painkillers, particularly codeine and opiates, of getting this medication overuse headache. So if he's using codeine for more than 10 days in a month, that's a risk for medication overuse headache, which complicates matters.
Yeah,
And so just calling a headache,
he's
giving him
gluten
paracetamol. Sorry?
He's gluten intolerant as well, which he
Right.
really dislikes. The fact all he wants is bread, bless him. And then he's also got to, because he's having the codeine, he's got to have what's it called, Laxado, to kind of counteract. So we're going around circles.
Constipation is a real problem with learning disability as well. People are prone to it. So you've got a really good argument that this needs to be looked at. What I would tend to do is to contact the learning disability community nurses and ask if he could be seen. Has he got a learning disability nurse?
We've got a relationship with our local team. We're in Havering and they're fantastic, so we can
and I would ask them for help with completing one of those diaries that I mentioned. Something like the Migraine Trust headache diary would be fine. Anything like that. You need to keep a record of showing it and recording his medication as well when he's having the medication. And the learning disability nurse can then support you with the GP. And I would have thought the learning disability nurse needs to be actually involved in the consultation, because the doctor may not be listening to you. This is the problem. You're describing a story that it could be migraine, but the doctor just doesn't seem to value your opinion. And this is a shame, but it's been repeatedly identified as an issue for carers. So you're not alone. Sorry?
we've got a system on our care note system called GP Connect, and we're able to see their notes from the last 3 appointments. So we got off of our last appointment a few weeks ago, looked at their notes, and it was just headache. It's like, no, why didn't you say headache? It's a minor headache.
Minor headache, but banging your head on the wall is not a minor headache. No, it suggests he's got a severe headache. I mean, I'm not sure about the blinking eyes, but it does make you wonder if he's getting an aura.
Yeah, you know, it's only been the most, like, the last 3-4 weeks we've noticed that and thought, hang on, that could be a thing.
Yeah, I mean, there's lots of other possible reasons, and I think that generally you definitely, I would say, high priority, contact your learning disability nursing service, the community team. Tell them by all means to contact the Migraine Trust as well, because they can share with them any information, you know, if the doctor needs some help. I know on the Migraine Trust website there's so much information that the doctor might want to look at about migraines, and my feeling is that this man does need looking at carefully, because it's how many days a month would you say he has the headache?
Oh, he has it like 2-3 times a week.
Right, so he would be someone that you'd probably be looking at as well as an acute treatment, then a preventative treatment that doesn't make him constipated. Yeah, but if you've got that diary, please do come back to the Migraine Trust if you're not getting anywhere, because they can contact me and I can support them further. Obviously, you know, we can't go into full detail here about this man, but I'm sure you go through the Migraine Trust and they can then reach out to me if you're not getting anywhere, and we can have bang our heads together. Is there anything else, Jessica?
No, that's really helpful. Thank you so much.
You've given me a really good case there, so I'm very grateful. Thanks for your question. I really hope you get success. But it definitely, to me, I don't know what you think, Debbie. Would you say this is suspicious that this man's got a migraine from the sound of it?
Yeah, I mean, it certainly needs further investigation. I would suspect it might even be cluster headache if the pain in somebody is that bad that he's banging his head on the wall. So there's definitely something more than a headache going on, for sure.
Yeah, he needs a proper examination as well, doesn't he? Because it could be a secondary headache. You know, you don't know until you've actually done the physical exam. And, you know, and I think it sounds like a learning disability nurse would be supportive to the carer, to Jessica, to get that treatment. Yeah. Thank you. And is there another question from Jenny? Oh, hang on. No, I've got that one. Jenny, I have a special interest in migraine, often manage those patients in my surgery, never thought of managing it in LD. Now thinking about, hang on, I can't see that. Now thinking about a patient with LD that I see regularly, and now thinking, oh, thank you, Jenny. Do you mind coming on the screen? I love to be able to see these people who've given the questions, but if not, that's fine. I understand, because we're recording, so you might not want to, but I would agree that this is really good news to hear that this sounds like a fellow GP and never thought about managing an LD, but is now thinking about it. What do you think, Debbie? That sounds promising, doesn't it?
Music to my ears, and I can definitely put that in a report somewhere for sure. So thank you, Jenny.
Yeah, so I'm an ANP in general practice, and,
hello.
And we've got quite a large population of LD, about 130 on our list, which is exceptionally large, of which I deal with all of them. I could probably name every single one of them, but we get a lot of acute on the day symptoms that appear, which often don't seem to have any kind of real basis in illness. So, you know, stomach pains, some self-harm issues, vomiting. I can think of one off the top of my head now. I think they often call with him being sick, and he's autistic, you know, and he head bangs, and when he gets really distressed, he swallows things, you know, and you kind of think now, you kind of look back and think, well, actually, do you know what? Is there something else? Is it not? It's not just the behavior that this might be. This actually might be. There is something else underlying, and it genuinely hasn't been. I mean, I've been involved with the Migraine Trust for years as a migraine sufferer myself, and I sit on the patient the patient forum as well. So I've had a lot of input, and done lots of training with the Migraine Trust, and I have to admit, never once in all of the time of all of the forums and all of the training have I ever considered managing migraine, or actually that they could suffer with migraine and not be able to tell us. And I put another comment about the general issue of assessing the medical needs. I'm doing the RC, the Royal College of Physicians current new learning disability module, and it's really made you kind of consider that, in fact, there's lots of conditions like this that we just genuinely never even crosses our minds that this might be something that's affecting them. So this definitely has made a huge thought in the back of my mind now.
Oh, Jenny, that's wonderful. I mean, we don't know, do we? That's the honest answer is, as me as a doctor, you as a specialist practitioner, it's something we don't think about, and I think we should. And I'm really grateful if we can, through the Migraine Trust, again, let's try and get something going, Debbie, where we start to look at this. I think we may have been missing it. And if it turns out, even if just one person can be helped with those kind of issues, because you realize that actually it might be migraine, and there is a way to at least try a preventer or two to see if it makes a difference. I think it's definitely worthwhile. Or just an acute treatment that could be migraine. Let's try an acute treatment approach. I mean, fortunately, the acute treatments sometimes seem to work, like paracetamol, aspirin, but an ibuprofen, sorry, an aspirin, but actually the triptans, if they're suitable, could be an option to try, or preventative treatments, I think, could be very much worth looking at, depending on their health problems, as a trial. This is what we do. Sometimes we think, well, let's try this, because they're often, people with LD have so many different conditions. The average number is 11 comorbidities, so you have to be really careful. I'm sure you have that problem, Jenny, of choosing what's the right drug. But thank you. So is it okay, Debbie, if Jenny keeps in touch through you, and maybe down the line we can get together and discuss what we find, because it sounds like we could really join forces. I see Paul's got his hand up. Is that okay?
Question,
Go ahead, Paul, and join us if you like on the camera. Hello.
Can you hear me? I've got to work it out below my hand now. I think actually the thing that struck me about this teaching session is that I never really thought about migraines, and I'll speak to my team. I'm a community nurse for learning disabilities, and I think we need to section on the nursing assessment which looks at the possibility of all forms of headache, really, because I think it'd be very hard to diagnose a certain type. When I was thinking about what Jessica said about the blinking, I mean, the first thing that came to mind then, if I heard that, would be, well, that's potential epilepsy. And actually, maybe I'm always tend to be thinking about epilepsy because it's so common in that client group, and it could be other things. So I think I'd like to put that on the nursing assessment, and then have that in the back of my mind, really, as a possibility, because statistically we assess I don't know how many people in a year, so some of those people are going to have migraines. So
it's bound to happen, isn't it? Because learning disability can't make you immune to migraines. It must, that'd be unbelievable. I think they must be happening, but we don't recognize it.
So I think I certainly think that one way of diagnosing people is to actually be looking for it, isn't it? And if we're not looking for it, and often we're the kind of first people to be doing that, and then we can refer to the GP if we have any suspicions. I was also thinking about ways to communicate, and I mean, a common thing is the Makaton symbol for pain, which, you know, a headache would be this, or a hand ache or whatever. And I think probably that could, it sounds a bit obvious, but that could be at least something if somebody could do that to identify where their pain is. And I think it's just piecing it together. And I think the third thing to look for evidence is a possibility of filming somebody given consent issues, and if that's okay. I've worked with some people with epilepsy, and sometimes people have shown me things and I thought, well, that's not epilepsy, I think that's something else, you know. And I sometimes don't know what it is, but maybe it was a migraine, you know. So I think those are the things that just came to mind that I wanted to share. Really.
Thank you, Paul. That's really helpful. I agree. If we put it on, or at least if we raise it as an issue when you're doing an assessment as a doctor, a nurse, physicians, specialist, if it's in our mind, it should be, because we've identified Jenny has, we've identified there's definitely, we don't come across it as much as we might think. It's like, what was that Sherlock Holmes story about the dog who didn't bark in the night? There's an issue that people with LD are not being diagnosed with migraine, and they probably are having it, but we're missing it or treating it in the wrong kind of way. There's probably a more effective way. We're using lots of painkillers when actually, you know, like Jenny's patient, we're giving him constipation, maybe causing medication overuse headache without realizing it. So even just having it in your mind is a really important step forward. And if we can then start to describe some case reports of somebody who's been treated unsuccessfully and then responds well, it gives more evidence. And that's what I was looking for in the papers, and I couldn't find it. So I just don't think it's out there unless I've missed it. Thank you very much, Paul. I'm really grateful for that. And I see Jessica's mentioned that her gentleman has pica, and if you've not come across that, it's where you eat things that are really not edible, like eating stones and soil and plastic paper and cups and anything like that, which is an odd behavior. And in my experience, the only I've come across it with iron deficiency sometimes can cause it, or funnily enough, lead poisoning, which is, I don't understand it, but if you eat paint that's got lead in it, one of the side effects can cause pica. So I'm not saying, Jenny, you need to get a lead measure on your patient, but if he eats paint, old paint, I'd be looking at iron and lead levels, see if he's got enough iron in his system. But due to pressure in his head, he's trying to relieve it, so he's actually putting things up his nose, which is, you know, you can imagine, if, you know, I know people with toothache, they can fight their teeth, hit their face. You know, I've come across that, and you find a toothache and you treat it, and that self-harm stops. So self-harm is a potential marker. It could be a way that somebody with learning disability has got migraine. Thank you, Sue, for your
comment.
You, Patrick.
Any other quick questions, comments, anything like that? If you think of something afterwards, or you didn't feel comfortable asking it in a group setting, that's totally understandable. Please contact us, the helpline, email, live chat. Carrier pigeon will get to us eventually. It's either something that we can help you with, or we can pass on to Patrick. So don't think that this is just the end of it, and us as an organisation recognise that we need to do more, and this is just the first step for us to be able to hopefully offer more support and information to people with learning disabilities. I think there is just one quick question. Go on, Erin, if you want to type it, shout it out.
Hi. So I've got ADHD, and I've had sort of continuous migraines since the beginning of March, which has been great fun. But I think one of the most difficult things, one of the biggest problems I'm having with like being referred to a specialist is that sometimes, obviously, there's such a big focus on treating migraine by like avoiding triggers. And sometimes, so for example, eating trigger foods, you know, I'm getting the migraines anyway, but they can make them worse. But that is actually something that really helps me to sort of manage ADHD. And so I think it's quite difficult in that regard to, in some ways, kind of be taken seriously enough, and not that I'm kind of by the GP kind of not thinking that I'm doing this to myself, if that makes sense. And kind of having to explain, you know, I know I'm going to get a migraine anyway, and there are other things that are also affecting, you know, my ability to work and carry out daily life. But yeah, this is one way in which, unfortunately, it makes the migraine worse, but it makes these sort of ADHD more manageable. And yeah, I'm just sort of, what is my question? Yeah, it's sort of having cases where you have like a toss up. What is there some kind of approach to emphasize how important it is to have that compromise sometimes?
Yeah, I think I understand, Erin. I'm sorry to hear you're having such a difficult time with your head, with your migraines at the moment, and trying your best to manage them with your diet, but struggling to get a referral. It sounds like your doctor's reluctant to make that referral. I think I know we haven't got much time, but as a patient, you do have a right within the NHS to ask for a second opinion. And I'd be tempted, if you're struggling to get answers to your questions, it's perfectly reasonable to say, look, I'd really like a second opinion and get to see a specialist doctor. There may also be within the practice a doctor with an interest in migraines, and that's another option. And you could ask the receptionist if there's somebody with an interest in headaches and migraines, or definitely the Migraine Trust. Where would they go with this? I know keeping a diary would be helpful. I don't know. I'm not going to go into all the different treatments you've had, but that would be my quick pick. And, you know, I'm happy for you to put your question through to the Migraine Trust. And if they want to discuss it with me further afterwards, then that's fine too. I'm sorry not to be able to give you a definite answer, Erin, but to keep trying and don't give up.
I think even, yeah, just finding out, because for, you know, again, various reasons, it's difficult for me to find out what sort of help I can get. And so even just, you know, I didn't really know very much about getting a second opinion, that sort of thing. Yeah,
no,
okay.
You definitely can, you can get a second opinion if you're struggling, definitely.
That's great.
Thank you.
Thanks, Erin. Thank you so much, everybody, for joining us. Big thank you to Patrick, and thank you for all the discussion at the end. It's really, really helpful for us, and this might not be the last you hear from us when we reach out and try and get some help to move this further forward. So thank you all again for joining us, and have a lovely afternoon, and we hope to see you all soon.